Welcome back to part 2 of our series on tropical medicine cases. Let's go to case number 3 now. Let's start with case number 3. This is the case of a 47-year-old male who works in agriculture. He presented to the Colombian Institute of Tropical Medicine complaining of 2 ulcerated skin lesions which had progressively become worse within the past 2 months. These lesions were located on the posterior aspect of the right upper extremity proximally. They had raised erythematous borders and associated local lymphadenopathy. They were minimally painful, and he did recall a bite from a small mosquito. Depicted on the physical examination are the 2 skin lesions we just discussed. So based on these clinical findings, what would be your diagnosis? A, malaria, B, leishmaniasis, C, strongyloidiasis, D, leprosy, or E, Chagas disease. And the correct answer is B, leishmaniasis. Leishmaniasis is caused by a parasite which is transmitted by the Leishmania fly, its vector. What would you do next to make the diagnosis or confirm the diagnosis? Next, we obtain scrapings from one of the skin lesions. Ideally, samples should be taken from underneath the border of the newest or earliest skin lesion. Then, using aseptic or sterile techniques, you would put it on a thin glass and view it under the microscope. What we visualized was a structure that confirmed the diagnosis. Does anybody know what the structure is on the bottom right? This is an amastigo. Also, as part of my rotation, we visited a clinic in a nearby town called Necoclí, which is an hour away from Apartado. And this clinic was dedicated to diagnosing, treating, and following patients who had skin lesions that was suspected or confirmed to be leishmaniasis. Here I am with my professor and my attending, and also the nursing and medical student, and enjoying the beautiful view by the beach. Here are some of the pictures that we took at the Leishmaniasis clinic. You can see that there are different skin lesions at different stage of healing, which were presumed or confirmed to be leishmaniasis. Also, we can see that not only on the extremities you can find some lesions, but it can also affect the ear. In some cases, it was difficult to confirm the diagnosis, even though leishmaniasis was highly suspected, like in this case. This patient had a very large, non-healing ulcer. The direct test had been done twice, and still no amastigo or parasite had been visualized. Therefore, we decided to do a punch biopsy at the Colombian Institute for Tropical Medicine. Here, we are putting anesthesia and getting ready for the punch biopsy, which was taken and depicted in the picture in the right. The treatment used in the Colombian Institute of Tropical Medicine, as well as the clinic in Necoclí for leishmaniasis, is injected intralesional glucontime. You can use up to 20 kilograms weekly for 5 to 10 weeks for mild and cutaneous disease. For more severe cases, you need to use systemic glucontime, which is administered intramuscularly or intravenously. Over there in Colombia, they also use creams with natural herbs and components, and some oral pastes with the same components. More about Apartado. Apartado's main industry is the cultivation of bananas. It drives the economy in many ways. It provides jobs for the people that live there, and also the food industry is highly dependent on the produce from the banana fields. The workers in the banana fields are agricultors, and that is how they get exposed to the Leishmania fly, which explains the high incidence and prevalence of cutaneous leishmaniasis in the region. This is the story of two brothers. However, it is important to note that there are 5 family members with the same disease. Brother number 1 initially presented to the Colombian Institute of Tropical Medicine with a hypopigmented lesion on his back. He then developed a hyperpigmented lesion on his right leg distally, with loss of sensation as well as a diffuse nodular papular rash. Biopsy of one of the skin lesions showed, guess what? It was positive for AFB. He completed treatment with clofazimine, rifampin, and dapsone, and he is currently on treatment with thalidomide and steroid taper as maintenance. Brother number 2 has the same disease with evidence of sequela now. He has scarring from skin lesions on his chest, a claw hand, and he lost his right eye. Here we can see on brother number 1's lower back evidence of hypopigmented lesion we had described earlier. On his extremity, we can also see in the picture on the right some nodular papular skin lesions. Brother number 2 has sequela now. So on the picture to the left, we can see the claw hand. On the picture to the right, on the top, we could see that his right eye is the one he lost, and now he has a fake globe in place. And to the bottom, we can see the sequela and the scarring of his old skin lesions on his chest. So what would be your diagnosis? Is it A, malaria, B, leishmaniasis, C, strongyloidiasis, D, leprosy, or E, Chagas disease? Remember the AFB. Yes, our diagnosis is D, leprosy. More about leprosy. The AFB seen in the patient's skin biopsy was consistent with Mycobacterium leprae. It is important to note the association between the 9-banded armadillo and leprosy. Humans can become infected via close contact, handling, and accidental exposure. This animal can be found in South and Central America, but also some regions of the United States, such as Florida. The classification of leprosy can range from tuberculoid to lepromatous disease and borderline zones in between. I will not go into detail on each classification, but it is important to note these as this will ultimately dictate the treatment regimen. Now on to case number 5. This is the case of a 15-year-old male patient who presented to his primary care physician with an acute febrile syndrome of 2 days duration. He was initially sent home and instructed to drink Tylenol for his fever. However, due to persisting fever, he presented to the emergency department the next day. Subsequently, the patient was transferred to the ICU because of respiratory distress, and he also had low oxygen levels in the 85% range. The review of symptoms was pertinent for fever, chills, night sweats, extreme fatigue, weakness, retroorbital pain, myalgia, dark urine, and dyspnea. His family members denied productive cough, nasal congestion, sore throat, abdominal pain, nausea, vomiting, or diarrhea, chest pain, nuchal rigidity, skin rash, arthralgia, or spontaneous bleeding. What were the risk factors that we can link in this patient's case to a physical exam disclosed a tachycardic patient in respiratory distress with desaturation and fever. He was anxious and toxic appearing. His head and neck exam disclosed evidence of mucosal bleeding. He did not have any murmurs or lymphadenopathy. His lungs had bibasilar crackles and diminished breath sounds bilaterally. His abdomen was benign, and there was no evidence of edema, nor skin rashes, nor jaundice. He required endotracheal intubation as he was not following commands neurologically, and he also required mechanical ventilation. He subsequently developed subcutaneous emphysema. The CBC initially showed anemia, which became worse. His hemoglobin dropped from 10 to 7. We're not sure what was his baseline. His platelets were also dropping. He had thrombocytopenia initially, and then it went all the way down to 90,000. And he had transient leukocytosis with left shifting as well. There was no evidence of eosinophilia or monocytosis or lymphopenia. Interestingly, the coagulation parameters were normal and they were not prolonged. However, his hepatic function became abnormal. His AST and ALT levels were normal initially, and the next day they became elevated. He also had hyperbilirubinemia with direct predominance. His creatinine also increased from one day to the other, consistent with an acute kidney injury. He ultimately had an indwelling Foley catheter inserted as well. Other labs were abnormal too, such as CRP, lactic acid, and CPK, which were all elevated. This was the initial imaging that was taken at the emergency department he first presented to. It shows diffuse, patchy opacities bilaterally. What would be your diagnosis based on the history, physical exam, and laboratory findings? Is it A, malaria, B, chikungunya, C, dengue, D, Zika, or E, leptospirosis? Any guesses? Well, this patient actually had dengue fever. We did a series of diagnostic tests. Blood and urine cultures were negative, as well as a thick and thin smear for malaria. Interestingly, the IgG and the IgM antibodies for dengue virus were both positive, consistent with a prior infection and a reinfection. It is believed that infection with a second serotype, which you are not immune to, will induce a more severe disease because of immunological memory. Your immune system response will be increased the second time around, and this will contribute to more serious complications. He also had a dark field microscopy done, which was negative, and the IgG antibody for leptospira. However, it is important to know that the dark field microscopy is not the gold standard for diagnosis of leptospirosis, as this can be false negative in many occasions, and it could be a false positive. It is a useful tool, though, used in Colombia because of the limited resources that they experience over there in that country. In conclusion, we were not able to rule out leptospirosis co-infection in this patient, and he did have risk factors such as bathing in the river, and he might have been also exposed in the flooding in the field and in his house. So he was given supportive care because of the virus, and he was also given doxycycline empirically. We will never know if he did have leptospirosis. And this brings us to the end of my presentation. These are some pictures that were taken at the Colombian Institute of Tropical Medicine. To the left, we can see the ancillary staff, my attending, my professor, also the microbiologists and the nursing that all gave their services to the patients that needed them the most. In the top corner to the right is a group of children that stopped by my clinic on one of the last days of my rotation. And in the bottom is me presenting this very case of dengue fever to the crowd and the staff over there at the Colombian Institute of Tropical Medicine. I hope you enjoyed these tropical medicine